Welcome everyone to day 2 of Virtually Cochrane, an online event hosted by Cochrane UK and Cochrane Ireland. My name is Carla Soares-Weiser and I'm Cochrane's editor-in-chief. The theme of this event is about navigating evidence and uncertainty. This has been a year of considerable uncertainties in our professional and personal lives, and this also hasn't been a year that many of us had to navigate an infodemic, being faced with a huge amount of information, some accurate and some not. Cochrane and many other organizations have played an important role in producing and sharing healthcare evidence, and I'm grateful to all of you for your spirit of collaboration and for your hard work. For those of you that have just joined today, all sessions yesterday have been recorded and are available to watch in the event platform. There is also an introductory video explaining functionality of the platform in your timeline. In this session, COVID and beyond, perspectives on how Cochrane can respond to the needs of end users, you hear the perspective of 4 Cochrane key stakeholders, and they will hopefully challenge us by presenting their views on Cochrane's role in future response to global health crisis, how systematic reviews should evolve to respond to the stakeholder needs, what values Cochrane's bring, and the potential challenge going forward. You hear from Maureen Smith, the chair of Cochrane Consumer Executive, John Grove, the Director of Quality Assurance for Norms and Standards at the World Health Organization, Declan Devan, the Director of Evidence Synthesis Ireland and the Director of Cochrane Ireland, and Ken Steen, the Director of the National Institute of Health Research Evidence Synthesis Program. After the presentations from the 4 panelists, you will also have time for questions. The questions and answers section will be moderated by Professor Lisa Barrow. Lisa is the Senior Editor for Research Integrity and the Senior Editor of the Cochrane Public Health Network. As with the sessions yesterday, please submit your questions for the panel members using the Q&A function available on the right-hand side of your screen. If you find a particular question or comment relevant for you, please vote by adding a thumbs up on the question. We would like to address as many questions as possible, but we will start by the most voted questions. And without further ado, I'd like to introduce to you Ms. Maureen Smith. Maureen has a long history of collaboration with the healthcare system as a result of a rare disease diagnosed in childhood. She is the chair of Cochrane's Consumer Executive and is involved in several Cochrane projects, including co-authoring a chapter on systematic reviews for Guideline International. Maureen also served as in the board of directors of the Canadian Organization for Rare Disease and the Ontario Strategy for Patient-Oriented Research. Since the onset of the pandemic, Maureen has been very active with COVID evidence mapping and COVID end initiatives. Please welcome Maureen.
Thank you so much, Carla. So happy to be here today and for the invitation to join this wonderful panel. Oh, sorry, already. So I'd like to begin by acknowledging the land on which I live is traditional unceded territory of the Algonquin and Anishinaabe people. The Algonquin peoples have lived on this land since time immemorial, and I'm grateful to have the opportunity to present on this territory. So just a little bit about who are Cochrane consumers. So you can see that we're a very large group we come from a range of people such as patients, or people with personal experience of a healthcare condition, their carers and family members, and also members of the general public and people who represent patients and carers. And the network is there to support consumers in their dual roles as users of evidence and producers of evidence. And just a slide about our Cochrane Consumer Network executives. So I have posted the names and photos of all of our members, and we're currently recruiting a new member whose second language will be English. And just to say that I became interested in Cochrane 6 years ago, and my interest really is based from the fact that I'm a frequent user of the healthcare system as a result of this rare disease diagnosis. And also when I serve as a patient member on 2 health technology assessment groups in Canada. And I was often frustrated reading the patient submissions. They were based on outcomes that were important and relevant to them, but not necessarily what had been reported in the clinical trials. So I have a keen interest in that too. Oops, sorry. I'm using here we go. So I'm using the clicker. So as far as the impact of COVID-19, it really is a high point for evidence-based medicine, and never has it been such a commonplace term. But the same thing, and the same thing for the role of research in our lives. But never has there been more attention to the danger of everything that falls into the realm of the opposite of evidence-based medicine. So that's also on the rise. The definition of lived experience as a stakeholder has certainly broadened, like who isn't affected by COVID-19 in some way. And so that means that we have a larger group of potential consumer partners, which is a good thing for Cochrane. Personally, I'm immunocompromised, and my husband was undergoing aggressive chemotherapy for the first 6 months of the pandemic with 7 hospitalizations. So everyone, though, has lived experience with COVID-19 to varying degrees. And finally, it's typical today to highlight the importance of providing that evidence-based medicine to decision makers and policymakers. But I would argue that we're all decision makers. So every day we make personal decisions to what degree to adhere to public health guidelines, et cetera. We decide on whether to seek medical care or forgo it, or given the risk of contracting the virus, and all kinds of other decisions. And many of these decisions are made without consulting a healthcare provider for a variety of reasons, and they have a tremendous impact on our society. So going to the needs of consumers as users of evidence. So we're looking for trustworthy evidence that's available in plain language. We want to understand evidence-based medicine and why some of the recommendations change. So some people will see that as being contradictory. It's really important that we understand why those recommendations change. We want to debunk myths and misinformation, and we want the evidence obviously to be relevant to us and inform our healthcare decisions. So Cochrane has a lot of challenges given this, like how do we rapidly respond to the needs of all of our stakeholders? So consumers are about one group. And for consumers, how do we pivot from a focus on systematic reviews to rapid evidence synthesis products? What do you prioritize? And where's the roadmap? There just isn't one, and that's really difficult. So I put these slides up for people for information afterwards to take a look at how Cochrane responded. So there's a couple of pages here of helpful resources that we put out for consumers, a lot more. My favorite, one of my favorites is iHealth Facts from Evidence Synthesis Ireland. And the one that was most obvious and helpful was the one about drinking water every 15 minutes. I don't know what it was like in the UK, but in North America, people were hoarding toilet paper. So knowing that you didn't have to drink water every 15 minutes was really helpful given the toilet paper shortage. So that was just an example of one of the facts that I thought was really interesting. The other thing that we did, we provided resources in different languages. Well, that's really important for that outreach of Cochrane. And we had many knowledge translation initiatives on the go with the dissemination checklist and all of the KT resources. and continued working on our courses. And we didn't stop everything. We had to prioritize certain things, but we continued knowing that this was really important, and especially the research priority setting, to try to get consumers more involved in that. And for the initiatives that are underway, I'll talk in a few minutes about our Cochrane Rapid Response Group, but the Plain Language Summary Project is really important, and that's almost ready to go. And here's the statistics on evidence essentials, and you can see that during the pandemic, it actually was accessed more often. So that's very encouraging also. Okay, now shifting a little bit to consumers as producers of evidence. In the Cochrane Statement of Principles, we're committed to that. So that's also very important. Okay. So how did we respond to their needs? Well, we did a lot of networking. That's where the 1,800 members really came in handy. We created a rapid response group, which I'll get to. We did a lot of outreach to author teams and researchers, and we continued creating resources and training materials, even though everyone was quite busy with the pandemic. So our Cochrane Consumer Engagement Officer, Richard Morley, was able to tap into the consumer network to meet the needs of citizen involvement in global COVID initiatives and support our consumers and researchers. So, for example, many Cochrane consumers are involved in COVID End, in the citizen engagement part, in the COVID evidence mapping, and he fielded requests from consumer involvement from groups and fields and networks, and we were able to quickly respond to those needs. And we created a multi-stakeholder group, quickly mobilized in April 2020. And the goal was to make it possible for review teams and consumers to collaborate in rapid reviews. And right away, we built resources and developed a process, and 133 consumers volunteered so far for this. So, my clicker is stuck. Sorry. Here we go. It just moves by itself. Here are the members of the Consumer Rapid Response Task Group, who by then we're all working from home. We represent 3 continents, and that's my workplace in my RV for the summer where I was isolating. So 23 feet. Okay, so this is just a list of the resources that we quickly produced for author teams and for consumers. And the plan is for us to reconvene to try to meet the needs of the pandemic as it's evolving. So I've got 3 slides with all of the names of the rapid reviews that were 26 rapid reviews who have asked for consumer involvement. Only 3 have consumers as co-authors. The other 23 are at the peer review stage, but those are just that's the list of the rapid reviews for those who are interested in seeing that. And the road ahead is that the pandemic topics are evolving, like to include topics that are of great interest and relevance to consumers. So if you look at the early ones, it's a lot about clinical management. And now we're moving more towards public health measures, mental health system disruption. And so we see an even greater role for consumers, and we want to continue supporting them. That our perspective in the health research priority setting exercise is going to be very important as the pandemic moves. So what are we going to prioritize? And of course, involving more diverse consumers to address the health inequities that are being laid bare during the pandemic, and all of the opportunities to improve as the shape of the pandemic changes. Okay, and just looking to the future to end, I really believe that our focus should be on the dual roles of consumers as users of evidence and as producers of evidence, and that we're going to get better outcomes if we keep that focus, and to really involve us in health research priority setting exercises. The view of the traditional systematic review, it needs to be adapt to involving consumers in the different types of rapid reviews and the novel ways of synthesizing evidence now. We need to address those real life issues such as the misinformation and collaborate with patient and consumer groups. That's it. Whoops, sorry. So I look forward to the question period. Thank you, Carla.
Thank you very much, Maureen. I am very grateful for the consumer network and for your really speed response to our demanding and request over the past year. It has been really very nice collaborations. I'm very grateful to all of you. Thank you. It's now my pleasure to introduce the second speaker, Dr. John Grove. John is the Director of Quality Assurance for Norms and Standards at the WHO headquarters in Geneva. He joined the WHO in 2017 as the former Director of Information, Evidence and Research. Before joining the WHO, John was a Deputy Director for Evidence and Policy in the Maternal, Newborn and Child Health team at the Bill and Melinda Gates Foundation. John has a wealth of experience in global health strategy, spent many years in Africa supervising disease surveillance, program monitoring and evaluation, among other things, and as a lead US diplomat with host country governments and on technical assistance and resource negotiation. Please welcome John.
Thanks so much, Carla. And thanks for the introduction, and thanks to colleagues on the panel, and many thanks also to Cochrane and all of you for having me here today. And also just want to express my appreciation for the Cochrane enterprise in general. I think when the COVID response first began, I think it was the end of December, January, we knew we were going to be getting into a serious situation. I think one of the first messages I sent was to colleagues at Cochrane to just let them know that we were going to be reaching out and needing quite a bit of partnership. So today I want to talk about that experience. And first I'll just want to acknowledge some colleagues who had a lot of input into this presentation in one way or another, or who historically have been involved, such as Susan Norris, who's retired now, in helping us get more and more organized in terms of our delivery of guidance as the WHO. And so today I'll talk to you about some of the efforts we had already put into place, just so that you're aware and brought up to speed in the directions that we're heading. And then I'll talk about the onset of the response for COVID-19 and how that accelerated a number of our efforts and activities. And I'll end with a set of lessons learned and some implications I think we have as a field moving forward. And just to let people know, back in 2019, we completed a very rigorous process of looking at a number of WHO's processes internally. And one of the areas identified that really needed a lot more support was around the development of norms and standards products. All of our units develop norms and standard products, but we were lacking sufficient capacity and a centralized approach to provide functional support across the house and to be able to engage in peer learning about what works and what doesn't, and also to ensure the robustness of methods and standards. And so it was recommended also through an evaluation that we formalize a structure and we better prioritize the public goods that we're producing, and that we establish a department that actually owns the technical support and process support for all of those processes across the house. So that's the department that we've been setting up. And it's been a very interesting, almost, I guess, 2 years now since we were established. The main mission of the department is to really make sure that we are producing normative and standard setting products that have real impact on people's health and are designed for delivery and uptake and use at country level. And we have a set of functions that we're pursuing that really outline an end-to-end kind of process that starts with the scientific piece that's supported by project management and processes that brings the best methodological expertise and evidence to the work, and also then is fed into our dissemination platform. So we also have the WHO Press and the library within our group. So the whole idea is to bring all of these pieces much closer together to modernize and ensure that WHO is producing things in a high quality fashion, but also obviously with a bit more speed and predictability. So a few areas that we've made some progress already. First of all, we've established, we've always had the very strong, for many years, the grade approach, the guidelines review committee that was implemented. And now we're able to also take a closer look at the non-guideline products that WHO is producing as well. And so we've come out with an agreed criteria for quality assurance that we're using across our different technical programs, across our units, that looks at the inclusiveness of stakeholders in the process, the management of conflict of interest, appropriate clearances for the process piece, for methods, making sure that we're applying the most rigorous approaches that we can, transparency, reproducibility of results, the best available evidence, and issues around gender equity and human rights being addressed. Third area is around presentation, what is being presented in terms of the WHO style, but also formats that can be quickly used and adapted for the end user. And then impact being around translation into local languages and optimizing usability for impact in countries. So we've already started to redouble our efforts to promote these quality criteria across all of the products the WHO is producing. We're also looking at our timing and our processes, just in terms of how long does it take to get things done. And we've done a pretty close dissection on the varied timelines for production of guidance as WHO. It's not to say that the shortest, fastest way is the best, and it's also not to say that there aren't unexpected delays or things outside of everyone's control that keeps things from getting done. But we're trying to come up with a sense of the baseline, as well as what support is needed to help improve the quality as well as the speed of our guidance. We're also obviously cognizant of the technology around us and upgrading all of our processes and systems. We've put in place a best-in-class publishing system. We're also experimenting and using different formats of living guideline platforms, working with GradePro and with Magic App both. And we're also looking at how to design guidance early so that it can go into the hands of the user more quickly through technology. So we're working on some things that we call accelerator packages that actually deal more with the data elements that are needed to put into a specific system, as well as the written prose guidance that would be required. And along that front, this just shows a picture of how we're thinking about it in terms of the different phases of the development of a guidance and how we move it more quickly into a digital kind of component. And if you think about that design earlier in the process, you're able to deliver something more ready to use more swiftly. I think many of you are familiar with this slide. We're also really making the living approach to guidance development at WHO a top priority. It's actually one of the top priorities of our department when it comes to reporting out to our senior management. And we're looking at the conventional processes where we're looking at a years-long sort of cycle where we produce something, we get feedback, and we go back to the drawing board and update it again. And trying to look at a more living approach where we're closing those cycles and all the time updating information, gathering feedback, going back to the science, and updating it over time. And that view has helped us quite a bit when it comes to the COVID response. Another area is looking at what our country offices need to help better do adaptation and implementation and monitoring of guidance at country level. We're working on a technical package that explores specifically what is the guidance being introduced, who are the users and what do they need, the information that's needed, the decision-making that'll be happening. Importantly, what's the enabling environment, the structure of decision-making and politics and policy at country level, and then a clear plan for moving that forward. So we were working on all of these things and still are, and along comes the pandemic. And on the 30th of January, the public health emergency of international concern was declared. You all have seen the numbers, you've seen the rising cases, the fluctuating death rates now on the rise again. And in the early time period, we really had to work with our emergencies program hand in hand to pull together really the basic guidance needed around some of the service delivery platforms that would be most impacted. We then moved into a process of going deeper into the topic areas that would need to be explored in the response. So we've quickly formed a rapid review group, which is now led by Lisa Askey within our methods and standards team. We were prioritizing topic areas that would be relevant to support the guidance and formats of guidance going out to the field. It started as a small group, still a relatively small group in terms of full-time equivalents. We have a handful of consultants helping us, but really importantly, we also have engaged across Cochrane and many other networks to work together on different types of evidence reviews. So at the moment, we estimate about 114 different reviews of different sizes and shapes, from simple to most difficult. And these are all then fed into our interim guidance and also fed into our policy briefs. Also for the clinical areas such as therapeutics or vaccines, we have standing guideline development groups set up for those. And we also have the SAGE group for immunization that advises on that guidance. So many different forms of guidance were produced. Another thing we put into place was a publications review committee, a central committee that would from now on be launched every time there's a public health emergency of international concern. And it's a group of people working across the three levels of our organization, so people from the country level, regional level, and headquarters, to provide a review on each proposed basically publication that's coming out of WHO, to make sure that we're integrated with the main points and the policy points of the organization. Also to make sure that robust evidence has been brought to the process, and to really define that product and make sure that it's put out in a way that is useful to all of the users and provides a second view on kind of the transparency aspect, the efficiency, and provides an independent review on all of those products. And to date, the group has reviewed, I think, 1,000, almost nearly 1,000 submissions, with some 600 of those being published over time. As you can see right at the beginning, sort of February, March period was an extremely busy period of time. But what this basically has done is introduced a lot of interim guidance into the system, which then we need to go back and be constantly updating. And so we continue to do that in a much more a much more living manner, as I would call it. This then helps us to think about what are some additional ways to make sure we have that speed and rigor into the future. So I mentioned the SAGE group. We still have the GRC, which we've always had. We now have this new mechanism, Publications Review Committee, and we're also looking at a fast track review process for non-guideline products for WHO that we'll be introducing in 2022. One example that we've been trying to learn as much from every example that we can, and one good one for us is the dexamethasone corticosteroids guidance. We had a lot of the ingredients needed to help produce what we think is very good, well-grounded guidance. But it had a lot to do with coordination, a lot to do with a very motivated, very energetic lead, lots of support from our group, and also staging things where things needed to be staged, pulling the right evidence together in the ways that needed to be pulled together, and then the coordination with publication and journals and all of those folks who are going to be publishing the trials. So really the lesson here is many moving parts, but there are ways to help stage things up and put the mechanisms in place to ensure that speed and the quality. You may also be interested that we have established a WHO evidence collaborative for COVID-19. That's also in partnership with Cochrane and with COVID-End. And we try to meet once a month or every other month to share our priority questions as WHO, but also that everyone in the evidence review and retrieval community can hear about the things that we're thinking about, but also then to receive feedback and reports from other partners on the topics that they're exploring. And I think this is a really critical ingredient to work moving forward in the future, even in non-pandemic times. So some lessons learned, I think, just to summarize, and the implications are the fact that, bench science is moving very fast, and so must we. And so it almost pushes us to have an even better line of sight in the R&D pipeline that's coming towards us, and to be able to anticipate what might be coming through the system and to help stage things so that we're ready to move. The technology aspect of things both drives us, supports us, and also challenges us. Now that we're producing things on a faster scale, the expectation is to do that all the time. And we're also trying to explain to folks that in many cases that speed is warranted. In some cases, it's not the right fit, and that we need to make sure we're applying the right processes at the right time. Also looking at how different technologies can streamline and be efficient working together. I think another lesson learned is around the fact that we know that the review and guidance updating is a continuous cycle, and that we always need to be assessing the questions and assessing the uptake and use and the feedback into the design, but also the scientific questions. Another area I think is a lesson is to improve the literacy on the quality of evidence, decision-making, and trade-offs. It's one thing to provide policymakers with a brief or a set of evidence. It's a very different thing to help policymakers make really real-world decisions with respect to their economies, with respect to the political environment around them. So how can we support that? Capacity is concentrated in is actually constrained, but concentrated in the more northern parts of the world, but it's quite constrained in other parts of the world when it comes to evidence review, retrieval, and analysis. And finally, lots and as much collaboration and communication as we possibly can have with the different agencies that are trying to respond to different health situations, and to align as much as we possibly can with those priority questions that are coming from the policy makers and from the technical agencies. So with that, I'll close and look forward to the Q&A session. Thanks so much.
Thank you very much, John. For us in Cochrane to navigate some of these challenges in partnership with the World Health Organization was crucial for our response in COVID-19. I think, you've mentioned some of the key areas that we collaborated, I think was important, especially the priority setting, the balance between speed and quality, because I think was very important, but also the use of technology and innovation to respond to a crisis. So I'm very grateful and humble for your leadership and also for the collaboration. Thank you. Just a brief reminder before I introduce the third speaker, that if you have questions, you can add the questions on the Q&A function available on the right-hand side of your screen. These questions are going to be prioritized if they receive more votes. So please click on the thumbs up if you like the questions that you see on the panel already. Thank you. And now it's my pleasure to introduce Professor Declan Devan. Declan is the Director of Evidence Synthesis in Ireland and the Director of Cochrane Ireland. He holds the chair in midwifery and the deputy dean of the College of Medicine, Nurse and Health Science at the National University of Ireland. He's also the scientific director of the HRB Trials Methodology Research Network and the principal investigator for Irish Centre for Fetal and Neonatal Translation Research. Welcome, Declan. Thank you.
Thank you, Carla, for the introduction, and thank you, Cochrane Ireland and Cochrane UK, for the opportunity to speak with you on the perspectives of how Cochrane can respond to the needs of users. And the perspective I'm coming from is the perspective of a producer of evidence. The evidence synthesis community responded to the COVID-19 pandemic, and Cochrane has been an important contributor to this response. Working with evidence users, the synthesis community have collectively developed, adapted, or reused rapid response processes to provide timely evidence syntheses. I'd like to take a few minutes to describe some of the syntheses and processes we developed in Cochrane Ireland as part of our contribution to that rapid response, and reflect on some of the challenges and opportunities for the future. I do so being conscious that there are hundreds of others across the Cochrane and broader synthesis community who will have similar and indeed bigger stories to tell. These are some examples of Cochrane reviews that were led from Cochrane Ireland during the pandemic. A qualitative evidence synthesis on barriers and facilitators to healthcare workers' adherence to infection prevention and control guidelines for respiratory infectious diseases, led by Catherine Houghton in NUI Galway. A rapid review on video calls for reducing social isolation and loneliness in older people, led by Chris Noon in NUI Galway. And a Cochrane scoping review on care bundles for improving outcomes in patients with COVID-19 or related conditions in intensive care, led by Valerie Smith in Trinity College Dublin. We also contributed to reviews led by others. For example, an update of Josh Verbeek's review on personal protective equipment for preventing highly infectious diseases due to exposure to contaminated bodily fluids in healthcare staff. We went where the evidence synthesis needs were prioritized, and this included rapid reviews outside of Cochrane, including, for example, a rapid review for the Centre for Evidence-Based Medicine in Oxford on extended use or reuse of single-use masks and respirators, led by Elaine Toomey in the University of Limerick. All of these reviews were done rapidly, and let me give you two examples and tease out a little bit more about what we meant by rapidly. So this rapid Cochrane qualitative evidence synthesis by Catherine Houghton and colleagues on barriers and facilitators to healthcare workers' adherence with infection prevention and control guidelines took 25 days from inception to publication, with the bulk of the work taking place over a 2-week period. And albeit rapid, the review is rigorous and robust, and any compromises are identified clearly. So I think we'd agree that's quite a mammoth undertaking to complete a qualitative evidence synthesis to the standard it was completed in such a relatively short time frame. There are several important factors, though, that influence the team's ability to complete the review to such a high standard within this time frame. The team itself included experienced reviewers, including qualitative evidence synthesis experience, experienced qualitative researchers, information specialists, and topic experts. The team were supported by a broader team, including the editors within Cochrane, the review group, peer reviewers, translators, healthcare workers, and end user stakeholders. The commitment and expertise of the author team themselves and the support they received from the broader Cochrane community was critical in completing and publishing this review within the time frame available. If you're interested in hearing more about the story and the reflections behind that rapid qualitative evidence synthesis, I encourage you to read this paper by Linda Beastie from the author team, which makes really interesting reading about the processes under the hood of that rapid qualitative evidence synthesis. The second example I'd like to mention is the Cochrane Scoping Review on care bundles for improving outcomes in patients with COVID-19 or related conditions in intensive care. This review was requested as a scoping review by the WHO with a 2-week timeframe. Again, the key components of being able to do this was an author team of experienced reviewers and clinical topic experts supported by Cochrane information specialists, editorial processes, review groups, and other people. This review also highlighted the importance of close collaboration between Cochrane and the WHO and the author team in refining the question to meet the commissioner needs. I'd like to reflect for a few moments on what I see some of the challenges we have now and for the future, and perhaps some of the things we need to consider. Much of the evidence synthesis ecosystem was, I believe, inadequately developed had inadequately developed systems and processes to meet the needs of decision makers as quickly as decision makers wanted the evidence. Cochrane has demonstrated that it can mount the evidence response that decision makers need. And Cochrane must, in my view, continue to be responsive if it's to remain relevant. We have, however, much work to do as a community to develop the systems and processes necessary to continue to respond in a sustainable manner to the current pandemic and prepare for future ones. My experience over the last year has been that the processes for the prioritization of research questions or evidence needs is far from adequate. We saw during the pandemic research teams ready and able and waiting on occasion to respond to the evidence needs of evidence users who at times themselves seemed to struggle to prioritize their evidence needs because they too were overwhelmed. This, coupled with duplication of ad hoc prioritization processes across evidence users, including policymakers and evidence providers, meant that duplication of effort was likely, despite effort to try to minimize that. Cochrane, I think, has a vital role to play in supporting decision makers in prioritizing evidence needs, but they can't do this alone, and this needs to be in partnership with decision makers. We also need to look at prioritization from a global perspective. Yes, context will always matter, but many of the same questions will be a priority for many countries. We've seen that. There have been some critical initiatives to help minimize this duplication of effort. Key among those is COVIDend, which is an umbrella organization involving over 50 evidence synthesis organizations or evidence support organizations that are working together to promote collaboration and reduce duplication of effort in the conduct and translation of COVID-19 related evidence syntheses. Public and patient involvement in research has been under pressure in this rapid response research. The pandemic has impacted everyone in society, and the standard rules of engagement have been discarded on many occasions. And while there are good examples of PPI during the pandemic, I think the overall impact has been negative and significant. As my colleague Adele Murphy in Inuit Galway says, PPI is important, and now more than ever. Cochrane has a long history of trying hard to have meaningful and purposeful PPI, but traditional processes, I'd suggest, don't work in a pandemic, and we need to rethink and reshape how we strengthen PPI in all we do, including those underpinning processes. Global approaches to generate and synthesize evidence for tackling COVID-19 and future pandemics must consider the challenges faced by research teams in low to middle income countries, challenges both conceptually and practically. And those challenges are above those faced by other research teams, because every research team, I'm conscious, has faced challenges. I think those in LMIC, low to middle income countries, have faced additional challenges. And we need to consider how we can develop meaningful and purposeful ways to strengthen and sustain the voices of low to middle income country researchers and evidence users on a global scale. The pandemic focused on very acutely on the need for evidence to be synthesized rapidly and updated frequently. This has accelerated the need for the initiation of a large number of living reviews. And I need no convincing of the value of living reviews. Cochrane Ireland has the privilege of being involved in COVID NMA, which is the living mapping and synthesis of interventions for the prevention and treatment of COVID-19, led by my colleague Isabelle Bouton of Cochrane, France. What concerns me, though, is the sustainability of living reviews broadly. Sustainability in terms of coordination of the reviews and the ongoing updating of the reviews, the editorial support process to support the reviews. If I'm honest, I'm not convinced that all research teams who initiate living reviews realize the task ahead, nor that funders appreciate the mammoth task that is to maintain large living reviews. I'm not suggesting that funding is the only solution, but it is part of the solution. And coupled with other potential models to keep such reviews alive is something all stakeholders need to face head on. So to conclude, it's been challenging to respond to the evidence needs of decision makers with speed. It's been achieved on the back of goodwill, hard work, strong collaborations, supportive partnerships, and personal sacrifices by many internationally. It has also been enormously rewarding, though, to play a small role and contribute to addressing the challenges this pandemic has brought us all. Within Cochrane, I think we have much more to do. We've also learned so much along the way, and I think the future is full of opportunities. Thank you.
Main opportunities for us, and I hope we'll continue to work together. Thank you very much. So I want now to introduce our final speaker, Professor Ken Steen. Ken has been the director for the NIHR Evidence Synthesis Program since 2018, and he also leads the NIHR commissioning of Cochrane and Campbell reviews and support the NICE Technology Appraisal Program. Ken is the found director of the Peninsula Technology Assessment Group at the University of Exeter, and he is the editor-in-chief of the NIHR Journals Library, which ensures publication of all commissioned outputs from the 5 NIHR research programs. Please welcome Ken on his presentation. Thank you.
Carla, thank you. Thank you very much indeed for the kind introduction and for the privilege of speaking on this really interesting panel. My position here is as you've said, as a funder. Although in fact, I can have all of these perspectives. I have a long and complicated medical history, which makes me a keen and enthusiastic user of Cochrane reviews to beat my physicians with. I've been a producer of over 100 systematic reviews, and thank you for the advertising of the Peninsula Technology Assessment Group in Exeter, which I founded. As a policymaker, I'd say there's an overlap with what I do, and Maureen touched on this as well, in relation to broadly evidence synthesis, because health technology assessment is a kind of evidence synthesis that brings together systematic reviews and cost effectiveness analyses, at least in the context of the UK and its NICE work. But it's a very important issue, adopting different technologies, and that's in the round as well as specifically in the context of a pandemic. So I can claim, I think, all of those 3 hats as well around this table. But here I'm as funder, and interestingly, I'm not the only funder within NIHR. We're spending around £1.6 billion on research, and within that is a great deal of evidence synthesis. I'm currently involved in a project looking at what the reach of that has been within NIHR and who has been requesting evidence synthesis and for what purpose. I think that's a good news story in the making, because evidence synthesis, as we all know, sitting around this table, is hugely influential. And the places where it comes from within NIHR are not always clear. But Carla has outlined my specific interests here, which is around funding Cochrane and Campbell reviews, but also supporting NICE's work. So there's 4 very interesting questions here that we're being asked to consider. So I just thought I'd just touch on each of those. I should say that my involvement in COVID has been considerably less than some of the other people around this table. In particular, Declan, John, well, everybody who's spoken so far. So I have to confess to having been much less involved. And that's because our funding, our approach to funding in relation to Cochrane, at least Cochrane and Campbell, is predominantly infrastructure funding. And then beyond that, once the funding has left the coffers and gone into any of the review groups that do the work, or to the teams that have successfully bid for programs, after that, our involvement is slightly more hands-off. But anyway, I think the questions that you've posed here are very good, and so I will briefly touch on all of those in the hope that I might stimulate some interesting conversation. So generally, how should systematic reviews evolve? Well, it's been a long course of evolution so far, and very interesting. And my position as a funder means that I'm acting for evidence users. I'm an agent for evidence users. And so I would like to see systematic reviews evolve in such a way as that they are better in fitting the needs of evidence users. And already there's been several things that I think absolutely resonate with me in the last 2 brief presentations. The need for speed. Timeliness is really important. We must land the evidence at the time of the decision. And we must have rigor in that. It's possible that there's a trade-off between rigor and timeliness. And I believe we must make that transparent. So using reporting guidelines as much as possible to be explicit about what the methods are that have been used is crucial. And one thing that has happened in COVID is there have been some dreadful reviews published, a very large number of barely, if at all, systematic reviews. And a lot of the thing that characterizes them is lack of transparency about the methods that have been used. Fitting to the question is critical. And clear links to the priorities. And again, this is something that's just been said by Declan. And it's important that we funders are linked in prioritization with end users. One of the issues for Cochrane is that the prioritization is accepting what we fund in specific reviews or programs of reviews. It's up to Cochrane to establish the priorities within the structure. I would say in the future, they should evolve using a lot more machine learning and artificial intelligence. And I'm just going to be provocative about that and hope that somebody will come back with a question that I don't understand. What values does Cochrane bring? Now here's the list, everybody will know this. This is the list of Cochrane's principles, and they are absolutely super great, but they don't all operate consistently. And I've tried to highlight a few buts here that I think can make us think in relation to these issues for Cochrane. So building on enthusiasm, this is one of the, I think there's a historical trail here to look at in terms of the development of Cochrane, starting with a lot more volunteerism than I think, at least in the UK, we see currently. I suspect that will be different in other health systems, and that goes to an issue around globalness that I'll perhaps touch on in a moment. But volunteerism has really significant limitations in terms of developing the necessary skills in people, competing for their time against other priorities. And in the context of a pandemic, are we talking about health service professionals being involved in doing reviews on a volunteer basis alongside dealing with the tsunami of increased demand and frankly, really challenging situations that all sectors in health had to deal with. I think volunteerism under those circumstances has very significant limitations. Minimizing bias is critical, going to rigor. And how do we balance that with timeliness? I've touched on that, and that will have been key in Declan and John's minds in terms of rapid reviews. Where is the trade-off? How do we make sure that we are as certain as we can be about what we're saying in the context of reviews? Because we can't be exhaustive to the nth degree in the context of really pressing priorities in time terms. I think all we can do under those circumstances, my view, is to be as explicit as possible. Promoting access is a big, has for long been a principle of Cochrane, but open access is a really significant problem at the moment for Cochrane and the Cochrane Library. I won't say any more about that at the moment, but it is a real issue. And ensuring quality. One thing I would say about that is variation in quality, and variation in quality between, I've said, Cochrane Review Group level, but also within time and in the circumstances. So how do you ensure quality when we're trying to operate under the crushing weight of the demands of pandemic? I think is a very real challenging question. So challenges going forward, I think there is an issue about global versus local, and how Cochrane can manage to be operating at a global level as well as at a local level, particularly when there is the structure, again, at global and local. And how do the tensions between global operation and local determination, how can those be worked out? And how can they be worked out in a way such that the arguments between the two levels don't actually consume more energy than any of us can really use? Open access, true open access, is not going to go away. Here in the UK, we don't know what the NIHR's policy on open access is yet. We have heard from Wellcome, and Cochrane, I think, has a very important job to look at how to ensure open access, which has been a very long-standing objective for Cochrane, back at least 9 years, as far as I'm aware. Flexibility to meet dynamic user needs is something that I think John has certainly touched on, which is that it needs change over time. And there's something I think which is important to mention here, perhaps, is living systematic reviews. And I think it's really important to have living systematic reviews. But from a funder's perspective, the question is, which ones should we fund and for how long? Where does euthanasia come into a living systematic review? When can we say enough? I don't know the answer to those questions, but I can tell you from a funder's perspective, an open-ended, we will fund this for as long as it needs, is not something that's very easily done when there are other competing demands. And those competing demands will have shifting priorities such that over a period of time, what you thought was the most pressing priority will suddenly become number 2, 3, or 103. How can we be sensitive to dealing with that very real challenge in living systematic reviews? Now, turning just to the question of the role in future global health crises, I thought it was very interesting hearing what was mentioned about WHO bringing together a collaboration around the ECC19 collaboration. And it may well be that collaboration across evidence collectives is important. We've got Cochrane, we've got Campbell, we've got JBI, and that's just international collaborations. There's the GIN, and if we're thinking about from where systematic reviews can get purchase on practice through guidelines, well, clearly what the WHO has been doing, what NICE in the UK is doing, and the GIN, for example, is critical. How do we bring those things together? I think is difficult. Can we see something over the top of these different collectives that can pull together in the way that WHO has been trying to do with the ECC19 initiative, that could respond in real time or briskly to a new pandemic, the next pandemic? Or indeed, and here's my last word, I'd like the unacknowledged massive challenge that we all face, perhaps to be where we think about how to collaborate across the top of our evidence collectives, planetary health. How can we bring in the collaboration for environmental evidence alongside the different collaborations that we're all involved in one way or another, to be thinking about what the implications of climate change are and how we can ameliorate them and how we can bring evidence to bear in that field. Thank you.
Thank you very much, Ken. By all means, you've put for us some important challenge, and I think that would be interesting to hear from the audience about questions. But before we go to the Q&A, I'd like to welcome all panelists to the screen and introduce to you Professor Lisa Barrow. Many of you know Lisa. Lisa is our senior editor for research integrity and our senior editor for the Public Health Network. Lisa has over 25 years of experience in providing international leadership for multidisciplinary teams that specialize in integrity and the use and implementation of research for health and health policy. She holds a professorship at the School of Medicine and Public Health in the University of Colorado, but she's also been a long-term contributor for Cochrane and has been an author, an editor, was center director, a member of the governing board, and a co-chair of the governing board. So she's really very much involved in all steps in Cochrane. But she also has been a long-time contributor of the World Health Organization, including serving as a member of the Guideline Review Committee and a chair of the Essential Medicines Committee. Thank you, Lisa.
Great, thank you, Carla. And I want to thank the panel for a very stimulating discussion and laying out a lot of questions. We do have some really great questions come in. Some have a lot of likes. So I'm just going to make some very brief remarks and then move straight to the audience questions. So the point of this was to hear from our stakeholders today. So what we heard is they want high quality synthesized evidence done quickly. It needs to be trustworthy. It needs to be understandable. And it needs to be on relevant questions to policymakers and people. So that's not too much to ask, is it, in a pandemic? No, that's not much. And actually, it's not too much to ask after a pandemic. So I think that we have heard some really concrete examples of how each of these stakeholders have risen to the challenge. So I won't repeat that, but what I want to emphasize is I think a lot of these changes are forever, and what our top maybe challenges are in terms of going forward. So we're still going to need to set priorities. And it was interesting to hear that our stakeholders have as much trouble setting priorities as we do sometimes for the reviews themselves. And so I think it's really important, these global collaborative initiatives, they can't go away. We need to keep those going on topics in addition to COVID-19, because that's how we're going to set priorities. In a way, myth busting and all this misinformation has done us a favor, because when a myth gets out there, it quickly goes viral, it quickly goes global, and it's of concern to a lot of people. So I think those myth busting questions have highlighted some of the collaboration that we've had. The other thing is that we have definitely moved beyond the traditional randomized controlled trial review of interventions. I thought it was very interesting that all of our speakers talked about scoping reviews, rapid reviews, network meta-analysis, living systematic reviews, and most importantly, reviews that use diverse sources of evidence that would address public health questions, qualitative reviews as well. In fact, the two examples Declan highlighted were qualitative and scoping. So Cochrane is already publishing all of these different types of reviews, and I think we're going to see a lot more of this in the future. Technology, there's no going back. Like, can you ever think that when a new technology is introduced, we stop using it if it's making things go faster? No. So we're definitely on the technology train. And capacity building is something that we really need to adapt to, and increase literacy, as was mentioned, and consumer involvement. So I think that, you know, Cochrane has done so much in these areas over the years, but we really need to update all that and keep it going in response to these new challenges. And just lastly, I mean, doing everything faster. John, I really resonate with you. Once you start doing things faster, everybody wants you to keep doing things faster, and that's just not always going to happen. Prioritization would help, but I think the bottom line is we can't do things slow anymore. I mean, there is an expectation to do things faster. And how do we do this without compromising quality? I think you all mentioned that. That is the key. And in fact, that is the top question that has risen for us today. So I think we do want some more comments from the panel on this question from the audience with the most votes. So the question is, in a crisis, which wins out, quality assurance or timeliness, and who makes the call? So I guess the question there is, when you've had to make a decision about doing something fast and compromising quality, how did you make that decision and who did it? So Declan, I think maybe I'll start with you on this one, but I'd be happy to have all the panelists chip in.
Thanks, Lisa. I'd be very happy for them all to chip in also. I think it's a really good question. It's a really important question. I guess my experience over the last year has been that I don't see it as black and white anymore. So we have good examples of rapid reviews done to a really high standard. There are examples of reviews that would traditionally may have taken a year, 2 years, being done in a number of weeks and days on some occasions. And that happens because it's always a balance between the speed with which the answer is required and the resources that are available. So for example, if you've got a really experienced team that are enabled to divert most of their time or as much time as they can to do this, or give up a lot of their own time, which lots of people have done in terms of goodwill to try and help, then you've seen examples of really high quality reviews done rapidly, and rapid not meaning that corners were cut. But I think the sustainability of that is really challenging. And that's something I think we really need to grapple with. That there may be some reviews, for example, that we want done rapidly to a really high standard where we don't want any compromise on quality. And there may also be rapid reviews that we want done, and given the resources that are available, there will have to be some restrictions introduced that may or may not, we don't know often, what impact that may have on the quality of the evidence. I think it feeds onto questions later on in terms of how we maintain these living reviews. Because maintaining that living review introduces other challenges in terms of, for example, as you know, well, at least in terms of the frequency with which these might be updated, the resources required to do so. And something that I think is missing in some of the conversations is around the coordination of those living reviews is a lot of work, but they can also create opportunities for capacity building within those living reviews, where you lean, for example, on some of that volunteerism that's very strong in Cochrane, but you can't just lean on that alone without offering something back. And that might be some capacity building in terms of methodological knowledge. Lots of people want to contribute to questions that are answering important policy questions. And we need to think about what structures and processes we can implement to enable people to do so.
Yeah, that's a great point. I mean, Cochrane is prioritizing what's going to get editorial support essentially for rapid review or not. But I think what you're raising is all the issues that would sustain those beyond that. Would any of the other panel members like to comment? And we do have, more questions. Yes, Ken.
Just to add a little bit to what Declan said, pretty much all of which I strongly agree with. So yes, if you have the resources to do the gold standard quicker, and if you have people friendly and willing enough to spend their time on it, then and that's great. Yes, leaning on the volunteerism will work. It won't be sustained for as long as we might need, as you rightly said. For me, three things perhaps further to say. One is to be completely transparent about what we've done. We must report things with maximal transparency so that the decision maker can think about what the corners that may have been, I wouldn't say cut, but may have been swerved a little, in order to get the answer in front of them quickly. Transparency, it seems to me, absolutely critical for that. And so failures to report according to the standards that we would like to see are a big deal. The other thing I'd say is automation in the future. I said I was hoping to provoke something by saying that I thought machine learning and AI could be helpful. Well, if it's another nearly 100 years until we have a really good going viral pandemic, I think it'll be rather sooner. But perhaps we will be further down the road to AI and machine learning helping us. But the other thing I think perhaps to think about is what are the risks of harms from what we do differently when we are stepping back a little from what we regard as the highest possible standards. Are we like to be, what kind of harms might we be bringing in from the for the decision maker? Be transparent about those is what I'd say. But if it looks like it's hard to see that there could be any harm, I think that the quandary then is how long do we expect people to wait if we think we cannot really make things any quicker? Thank you.
John, sorry.
Yeah, I'm happy to comment on that. It's something we face every day, as I think you can imagine. I guess in my mind, it's hard to separate the evidence process with the ultimate product, with the actual guidance that's being produced. So maybe that's my perspective more for the response. But I mean, I think what we've been faced with is, the early phase was really what evidence is there for similar types of outbreaks. When it comes to the response of the system, the public health measures, the surveillance needed, case definition needed, all of those kinds of things. And so at that point, you're sort of relying on the history of other evidence that's been gathered and collected. And so in other cases, you're having to do something completely novel, right? From the beginning, you're pulling together all of the data, you're doing the meta-analysis, you're pulling a new GDG together. And so the evidence that drives that process is a little bit different. The one thing that we've done to try to make sense of that, and literally we're for us, it's can be a 12 to 48 hour alert that we need to respond to. Doesn't necessarily mean that the guidance would be ready in that period of time, but it's very quick cycles. And so the do no harm principle is very important. The other thing is around our review committee has introduced a series of product types, which helps our partners or helps our technical units know just what kind of strength of evidence is needed to match that product type. In some cases, someone's putting forward what they call a guidance, but it's actually an advocacy brief or a more objective statement. It's not written as a recommendation. And so the data is well summarized to a certain degree, but it's not necessarily the strength of evidence that would be needed for more invasive kinds of interventions. So it's not a one size fits all, but having a couple of these structures and ways to help teams make those decisions. At minimum, the methods need to be strong, transparent, conflict of interest needs to be sorted out and clear, and do no harm, I would say. And then who makes the call? The recommendation comes from the group doing the quality work, doing the synthesis work, and eventually, senior management will make a decision. And then there's a whole other set of factors that come into play, as you can imagine. So we do press conferences twice a week with our director general, which I think some of you have seen in the news. So that's always a good place to go if you're looking for the latest as well.
Great, thank you. And Maureen, we actually had a specific question for you on this topic about how the consumers get involved in the rapid review process very specifically. So perhaps you could address that, and then we could move on to another question.
Sure, I can do that. Thank you. I'm unmuted. Okay. So the timeliness, as you in the previous question, that's I was going to comment, is very important, and keeping that the reputation of Cochrane for being a trusted source is also very important. So in the rapid reviews, when I showed that slide where it's a perfect storm for public and patient involvement, because there's more stakeholders, the research is more relevant. There, everyone's involved. It's a societal issue, and all the arrows are all pointing upwards, and the only arrow that's pointing downwards is the public and patient involvement. And a lot of that, the reason for that was based on the fact that it had to be done rapidly, and that researchers didn't have time to consult with patients and the general public. In Canada, our first round of Canadian Institute of Health research came out, and less than 30% involved patients. And I just saw the numbers coming out from the UK and IHR, and they're quite similar. So in the rapid reviews for Cochrane, we mobilized 133 people rapidly and offered them some training, but also worked with the researchers. So if we work in a silo, we don't get anywhere. We have to reach out to this multi-stakeholder group and say, here are people who are interested in doing it, and they know that it's rapid. So I participated in a rapid review from the World Health Organization and with Cochrane, and I was told ahead of time I would have 6 hours to respond. And I agreed to that because I want to be involved and I want to do it, and it was important to me. And our consumers who are signing up understand that. and they won't sign up if that's something that they can't do. We all understand how quickly the pandemic is evolving. So in the rapid reviews, we've offered them some training, but we can only do so much because the consumer doesn't have the power to put themselves on a team. The consumer is invited. So our big outreach is really to the author team to say we have people ready and we can match you up and we can support those people. So I think that the network, the biggest thing that the network could do during the pandemic was to support its members and to work with all of the other stakeholders in Cochrane to say we are ready to go. And because they had done systematic reviews, they were ready to do a rapid review. So that became of utmost importance. And those consumers on the rapid response team, we have integrated them in teams all over the world. We fielded requests, and we could write to them individually and say, COVID-N needs people, evidence mapping needs people, and these people are going to respond. So I think that was one of the things that I'm proudest about what Cochrane did, was to really mobilize its network. And the word network really came to life for me during the pandemic. We really are a network. I'll stop there.
So I think, Maureen, people will be contacting you to find out how they can actually get involved in this team, and recognizing, as we heard, the limits of this volunteerism, but this is a key component. So let me just move on to the next question. Thanks for all those great ideas. And the next question is, what could systematic review community have done better to reduce duplication and research waste? So I know some of you have already mentioned some topics in that area. So why don't you just give me one idea to reduce duplication and research waste? And John, I'm actually going to start with you because this was specifically asked what WHO could do in this role.
Yeah, so I think it's probably not a short answer, but one thing that we've put in place is this evidence collaborative for COVID-19, which is very much the evidence retrieval and synthesis and review communities. But then there are all of these other communities, right? There's the R&D community, there's the response community. And so sometimes it's a challenge keeping all of those straight, but those are the things that we've done. And I think the goal is so we also have a research and evidence roadmap that was developed back in February 2019, which has been a large, sort of driver of kind of the framework and architecture of how we're approaching this. I would like to think that the evidence collaborative has helped to reduce some of the churn because we've tried on a monthly basis to, really communicate some of our priorities and also let people know what's in play. And then that creates a kind of marketplace to get a sense of who's working on what. So I think that's one big thing. I think the other thing that I would like to see more of, but I think we haven't quite tackled yet how we will engage directly, but is the registries, guideline registries and other, obviously we have the libraries of reviews and things like that, but also promoting this idea of guidance registries as well in the future to see, again, to me, I can't separate the evidence from the end product, but a couple ideas.
I like that. Very fun. Other ideas for reducing duplication and research waste? Ken?
One thing that I can say that I did in the context of COVID was in February last year, I increased the funding to Prospero to be able to take on what I could see at that point was going to be an increase in the demands for registering protocols and making them available. And it seems to me that's a very important step in the necessary duplication, unwanted, I'm going to say wasteful duplication. So it was very good to be able to do that and to see Prospero rise to the challenge, actually, a lot of which it did alongside COVID-N, and it's great to hear that mentioned as well, in terms of trying to recognise again, tsunami is not a bad word, I think, for what happened over the last 12 months in terms of the quantity of systematic reviews or reviews of various types that have come out. Not everything will have been written a protocol, and it may well be that scoping rapid reviews, maybe people would believe they don't have to have a protocol. I would challenge that, actually, and say that we should. And what we need is a rapid system of making sure that those protocols are assimilated into an easily accessible format, as Prospero is, so that anybody thinking about the same question that's their first port of call.
Thanks. Any other ideas? I mean, I think that the registry point is so important. And as I'm sure you know, there's the Cochrane Registry of COVID-19. And what's interesting there is it's study-based. And so you can find out if there's multiple preprints to the study, to the protocol, one-stop shop. So I think those kind of things are really important, because if we can't link the data, we can't do anything very efficiently. So that just to our next question, we have really a group of questions around, and I think this will have to be our last question with brief answers, around basically the timing of doing reviews and the resource needs for doing reviews if you're not relying on volunteers. So what's the difference between like a regular Cochrane review and a rapid review? I think we heard from Declan, it's around 2 weeks to get a rapid review done. We heard from John that their turnaround can be 24 to 48 hours for certain products. So, what I guess people are interested in the timeframes and the person hours needed to produce these different products. Declan?
Thanks, Lisa. I think that's a really important question. I think it's a really difficult one to answer. I think it depends on the question, the scope of that question, the amount of evidence that's out there. So if you're taking a review, for example, that's including a handful of studies versus ones that might be including hundreds of studies. So for example, you can see in the future that some of the syntheses around vaccines, there may be a lot of evidence mounting there. If you go outside of randomized trials, there is a lot of evidence out there. The relationship between that randomized trial evidence and the observational evidence and how you bring that together. So I think it depends on the actual question and then the factors that feed into that question in terms of the types of studies that might be included, the volume of evidence that's out there. So it's really difficult to quantify it. And sometimes it's really difficult to quantify the resources that are needed at the outset. So that makes it challenging in terms of funding such reviews, where sometimes you're asked to fund something and stepping into a relatively dark hole. That's even more the case today when you've got multiple ports of sources of evidence in terms of preprints, in terms of that linkages of studies, as you say, Lisa. So I think I suggest that one thing we've got to accept is around the need for flexibility within how we do these reviews, to certainly refine the question, etc. But as many of you who've been involved here know, that as a question is asked, other questions may be prioritized within that, other sub-questions may be spurred off, etc. So it's having that continuous engagement with the commissioners, whoever they may be, and allowing that flexibility, I think, and it's really difficult to quantify beyond that.
I think that's a great point, Declan. And it's really highlighted too by the diverse types of evidence we are dealing with now. Some take a lot more to synthesize than others. So any other comments on that? John?
I think it's a great question. Again, it's another one without an easy answer, but I think it's important to invest in the coordination piece, right? And so I think our current thesis is the more we have sight on what's happening across the house in terms of different questions that are being explored, COVID or not, we can help actually reduce those additional costs to the units for continuing to pay for people to answer the same question over and over again. And so there's a trade-off there. So you put the energy and investment into a living process early on, and maybe the cost is high at the beginning, but then it pays, it's less cost later because you've structured it, you've really thought about it, you know it's going to be a continuing issue of concern, and you coordinate to the point where you're actually saving resources by putting in that thought up front. And then you're dealing with the more episodic things as they come through.
Maureen, last word on this one.
Yeah, so one of the things that we stress when we're working with consumers is always the relationship and relationship building. And you can just kind of forget about that as far as when it's going to go really rapidly. So it's more like choose two consumers, bring them in a few key points. And it's really kind of like a quick and dirty approach. So maybe at the beginning, you're framing your question. You probably don't have a lot of leeway there because the funder is really telling you what they want. But maybe are we missing anything? And then maybe at the middle, when you're analyzing your data, is this relevant? And then at the end, when you're going to bring it out there, that's when your consumers can also help you with the plain language and how to get it out. And so it's not one of these long-term relationships that you would have, but it's doable. And what we hear is that people are willing to do it, and consumers are understanding that it's a different world, and we don't want to not be involved because we can't have a long-standing relationship with you. So I think that part is really important. And we say perhaps 5 to 7 hours for the whole review, that your involvement might be wrapped up in that time or shorter, and there's a willingness to do that. So.
Great, thank you. I want to thank the audience for all the great questions. I'm sorry we couldn't get to all of them. And I really want to thank the panel members. And just to highlight here, I found this session very uplifting in a way because, when you hear from stakeholders, you hear a lot of challenges, but it was good to hear how we're meeting some of those challenges and have a lot of ideas about how to improve for the future. So thank you very much for that. And I'll turn it over to Carla to close the session.
Thank you all very much. I want to echo what Lisa just mentioned and thank all the panelists. When we put this session together, we knew that it was going to be challenging, and that, but I think Cochrane is up to the challenge, and we are really ready to move on and act on what we've learned during the past year. So thank you all very much, and thank you, Lisa, for the wonderful moderation. We couldn't have better people for this session. So, but this session is only the beginning of a conversation. We know that there is much more to be done, and we are very keen to continue our work and to get the learnings of COVID going forward in our production of reviews. But we also want to get more engaged with our stakeholders. So in October 5th to 8th, please, I'm pleased to say that we're organizing a virtual meeting called Cochrane Convenes. And the key idea of this meeting is to learn from the COVID experience, but also work with our partners to help prepare for future global health crises. So watch this space, more to come in terms of information about the Cochrane Convenes. And finally, some housekeeping. There is now a 30 minutes coffee break, and the concurrent session will start at 3:45 p.m. UK time. You can attend one of the sessions live, but all sessions will be recorded and you can watch later if you prefer. So with this, I want to thank everyone and thank all the audience for your wonderful participation. I hope next time we can do it, at some point we can do it face-to-face, but as virtual goes, I think it was really quite exciting to hear from all of you. Thank you and have a nice day.